Hello, everyone, and welcome back to the 5th episode of the Hyper IgM podcast. In today's episode, I have a conversation with the amazing Dr. Prockop, who specializes in stem cell transplants and has treated multiple hyper IgM patients. In this episode, we talk about what makes treating hyper IgM unique and often challenging. This episode of Patients' Voices is brought to you by Blue Jay Advisory. Blue Jay Advisory is a consultancy business that partners with international charities to strengthen their impact and mission. It was founded by Chris Sheesby, one of our rare adults living and thriving with hyper IgM syndrome in the UK, whose vision is to support organizations making a difference around the world. We're so grateful for their sponsorship, which helps us share voices and experiences of our hyper IgM community. To learn more, visit the link in the description. Thank you, Blue Jay Advisory, for supporting our mission. Enjoy the episode. Hello, everyone, and welcome back to the 5th episode of the Hyper IgM podcast. I am your host, Ezra Feynman, and today I am joined by someone very special to me, the incredible Dr. Susan Prockop. Dr. Prockop is the Program Director for Clinical and Translational Research in the Outpatient Clinic and an attending physician at the Pediatric Stem Cell Transplant Program at Dana-Farber Boston Children's Cancer and Blood Disorders Center. You know, with a title like that, she's an incredible doctor. She was also my transplant doctor when I was treated at Memorial Sloan Kettering Cancer Center. How are you doing today, Dr. P?
I'm great. It's so good to see you.
It's great to see you, too. So, before we get started, can you share a little bit about yourself, the specific type of doctor you are, where you work, and a little bit about you?
Okay, sure. So, to do bone marrow or stem cell transplant in pediatrics, your training for all of us is first in pediatrics, and then in hematology oncology, and then specializing from there into specifically stem cell or bone marrow transplant. And that field has grown. One of the things I love about it is how much it's grown. And so included in the field of stem cell transplant are other cell therapies, including genetically modified cells, both for cancer and non-cancer diagnoses. So that's what I do. I work at Boston Children's, which is an amazing multidisciplinary hospital that provides top-level care for all sorts of kids who need treatment. Our specific program is for bone marrow and stem cell transplant, as well as gene therapy and other cell therapies for both cancer or malignant disease as well as non-malignant disease. And about half of the kids we treat have non-malignant disease. What makes it so special is really having a huge multidisciplinary team, both within the transplant program and more broadly, like when we collaborate with colleagues in the gastrointestinal service or pulmonary or the ICU, makes for an incredible team approach to every child and making that care really individualized.
Awesome. Thank you. Definitely gives our viewers a great sense about you. So before we start getting into the nitty-gritty, for our viewers that don't already know what hyper IgM syndrome is, hyper IgM syndrome is a 1 in a million rare disease that causes a person's immune system to not function properly. People with hyper IgM are unable to make antibodies, which means if they get sick, they will most likely have a hard time fighting off the infection and could get very ill. Hyper IgM patients are also at a high risk of developing cancer. Without a stem cell transplant, life expectancy for a person with hyper IgM is an average of 30 years old. However, some do live into their 40s or 50s. So, with that being said, let's talk a little bit more about you. So, how did you get interested in becoming a pediatric stem cell transplant doctor? And why did you focus specifically on immune deficiencies? Because that's a very specific field.
It's a pretty narrow field. So, actually, right out of college, I was a dancer in New York, and then I sort of woke up one day and decided I was going to go to medical school. And during that taking classes and all that process, I worked in an immunology lab, and I really fell in love with immunology and the science behind immunodeficiency and immunology. And so then when I was in medical school and putting sort of the clinical components together, I really continued to like immunology. And so then you asked, why didn't I do immunology instead of stem cell transplant? But one of the things I really love about what I do is you can not only understand the immune system and the ways in which it's not working correctly, but also do something to fix it. And so that's really what drew me into transplant.
Wow. I mean, obviously what you do literally saves lives. So it's incredible that you just woke up one day and you're like, oh, I'm going to be coming from somebody that doesn't exactly know what they want to do yet. In the future, that's maybe I hope I have something like that where I wake up one day and it just comes to me.
An epiphany, right.
But yeah, it's almost like you're meant to do it. So now transitioning to more specifically hyper IgM syndrome. Mm-hmm. How many patients have you treated with hyper IgM? Because obviously it's a 1 in a million rare disease. So
I've transplanted altogether 6 boys with hyper IgM.
All right.
That's counting you. I only got to do one of your transplants.
Right. Well, you were involved with my first transplant, but for our viewers that don't know everything about my journey with hyper IgM, I had 2 stem cell transplants. The first one did fail, unfortunately, but the second one was successful. So, was I your first hyper IgM patient that you treated with transplant?
You were the first hyper IgM kid I treated. Yeah.
Number 1, that's me. Number 1.
Yep.
Yeah. So, since I was your first, do you remember anything from my transplant or transplants, because you were involved with the first one? I remember all the crazy stuff I did in my room. I'm curious to see if you remember anything.
So I think for your second transplant, we had just moved to a new unit, and you were one of the first kids in the new unit. Mm-hmm. So I remember we were all figuring out how things worked in the new rooms when you were having your second transplant. But yes, you were pretty active in that room. You had a pretty big room, luckily, because you were all over the place. Yeah. I think you spent a lot of time on the floor. Your mom did a great job of making the floor a safe place.
Yes, I did spend a lot of time on the floor. Do you happen to remember the dynamite building that I did in my room? You remember? Yeah, I remember all the nurses being like, "Whoa, what is going on in here?" I remember that. Yeah.
Yep, lots of small explosions. Yep. Luckily, they were all small.
Right, controlled and small, right, for the safety of everybody at Sloan Kettering.
Yeah.
Yes.
The other things, on a more serious note, that I remember about your second transplant was that you had a pretty significant complication, and it's sort of a not uncommon complication where people's immune system actually attacks part of their body, and in your case it was your red blood cells. So it wasn't the complication called graft versus host disease, which is more common, but it was a complication that was about your immune system not working correctly. And I think where it becomes important in the context of hyper IgM is that the treatment for that complication and some of the other complications we see after transplant is something that resets the immune system in a way that makes quite a few people again dependent on IVIG. And so one of the things that I think we all are careful about when we're talking about transplant and we're talking about the complications after transplant is sort of what have you done to cure somebody, and what are the things you could do after the transplant that sort of make it less beneficial. So when we have people who need to go back on IVIG, other parts of their immune system are working well. So you've still done some benefit with the transplant, but it is pretty distressing for families to sort of have chosen to go to transplant partly because you're getting rid of needing IVIG, and then have that thought that you might have to go back on IVIG.
Yeah. Yeah, like transplant is obviously very risky still, and that is one of the unfortunate downsides that could occur. So, keeping on the track of treating hyper IgM, what makes hyper IgM different from transplanting other immune deficiencies?
So, there are many ways you can think about how different immune deficiencies are different from each other. But one way that I think hyper IgM is different, and there's some other immune deficiencies that are like this, is that the indication for transplant isn't absolute. As you said, the life expectancy is certainly not normal, but unlike, for instance, severe combined immune deficiency, where the life expectancy is like 1 year, and it's an absolute indication to go to transplant, and people do it rapidly. With hyper IgM, that's not the case. You can decide not to go to transplant. You can sort of say, well, we'll go to transplant if there are bad infections or if X or Y happens. So that part is just the decision around going to transplant to begin with is very different and more complicated. And then there are a few specific infections that it's not truly understood why boys with hyper IgM are more susceptible to them, but one of them is Cryptococcus. And so many people who have IgM are very careful about exposure to different sources of water and things like that around Cryptococcus. And that can be life-changing. And so that's a little different about hyper IgM. And then, as you mentioned, sort of that risk longer term of especially lymphoma is also one of the things that's a little bit different about hyper IgM than other immune deficiencies. There's some others that have that same susceptibility, but it does make them different from each other.
So, yeah, like you talked about, it's not fully understood why hyper IgM patients are more susceptible to those specific things. Just like goes to show just how like still new like all of this stuff really is. We talk about like transplanting, and we have the Hyper IgM Foundation, and it's just formed around like it's still such a small base of people. It's very interesting to see how the field still does continue to develop and all this other stuff that's still unknown, which is still pretty crazy to think about, really. Yep. So we talked about how hyper IgM is different from other immune deficiencies. I feel like for some viewers, the most like readily like known thing that could be transplanted is cancer. Mm-hmm. So how does hyper IgM differ or compare to transplanting for cancer?
So there are a couple ways. One is, as we talked about, that decision to go to transplant is usually a little more black and white if you're transplanting somebody for leukemia. There's gray, but it's usually a little clearer whether somebody actually needs a transplant or not to begin with. So that's sort of the first step. Then the second step is how you do the transplant. And so when you do a transplant for a cancer, the drugs you use and the intensity of those drugs are in part targeting the cancer. You're doing the transplant because there's either good evidence that there's still some cancer cells left in their body, and so you want your drugs and sometimes radiation to be things that are going to kill those leftover cells. When you're doing a transplant for hyper IgM or for other immune deficiencies, you want to be as gentle as you can. You know that there can be long-term side effects from all of these strong medications, and you want to minimize the chance of that while still being sure that the graft sticks and stays and is able to provide lifelong good immune system. But that sort of is very, that idea of being as gentle as you can versus being almost as aggressive as you can are very different frameworks for how we start out thinking about transplant.
That's incredibly interesting. I had no idea that for hyper IgM and other immune deficiencies that you try to go gentler on the drugs. Whenever I think of like my transplant, I'm like, oh, they just like loaded me up with like, like medications and all chemo, and it's interesting to learn. Like, I'm learning about my own transplant experience right now. So you guys are learning this in real time with me. So it's to minimize long-term side effects. That's correct?
And short term, like
And short term, right?
there's
Yeah.
effects from the drugs even as you're administering them, and so minimizing both of those while being sure. So hyper IgM is one of the immune deficiencies where there's a slight increase, or sometimes not so slight increase, in the chance that the graft won't stick, that there'll be some form of rejection or graft failure. That means people need a second transplant. So you want to give enough medication in the first time around that you don't need a second time around, but while minimizing the chance for long-term side effects. Yep.
So that's a very precise balance that you have to decide how much to give.
Yeah, exactly. I mean, it's a balance we're learning over time. So I think being able to better measure how much of each of these drugs your body is actually seeing is something that's developed over the last 10 years. So we now do blood levels and stuff like that for some of these drugs. And so we can adjust in real time to be sure we're giving you how much you want.
And you said that you're figuring it out over time.
Yep.
Unfortunately, but fortunately, there's not that many hyper IgM cases to figure it out over time, which does perfectly lead me into the next question with how each hyper IgM case is different from each other. What are you seeing over time with different hyper IgM patients and studies that's come out about hyper IgM patients? Tell us a little bit about that.
I think so. There's a certain level of similarity, but there's certainly differences. As people understand more and more the different levels of, for instance, CD40 ligand on the cell surface and what controls that, I think some of those differences are increasingly being better understood. So some of the differences are, how old are you? What infections have you had before? Are those infections that are things that stay in your body and we need to worry about during transplant? Are they infections that could have affected how strong your lungs are, or how strong your liver is? Or are they more things like that your donor isn't a perfect match or is a perfect match? And so I think you're absolutely right that the total numbers are small enough that it's very hard to figure out which of all of those different components are the one or two most important differences. We can figure it out sometimes when we look at bigger groups of kids with immune deficiency and sort of put different types of immune deficiencies together in buckets. But the whole reason there's a hyper IgM foundation, I presume, is because it is different, and we want to be paying attention to those differences and not just lumping.
I was thinking about that actually when there's so few hyper IgM patients. How are they learning? And you've kind of answered that question for me with how you're able to kind of take data from other immune deficiencies and shift them over to hyper IgM. So that does kind of show that hyper IgM is kind of similar to other immune deficiencies. Yeah. So speaking of why it's different, what is most challenging about treating someone with hyper IgM? Is it the balance of how much drugs to give, like we talked about earlier? Is there another aspect of it that you find more challenging?
No, I think the challenging thing around transplant for hyper IgM is that there are enough boys who've needed a second transplant that we know there's a certain risk of the first transplant not being enough, whether it's that it's a mismatched donor and so it has a harder time sticking. Is it that the metabolism of the drugs are slightly different in one person or another. There are a lot of variables, but I think the overall is we know that there is an increased risk of the graft not sticking. And sometimes that's something that happens like right away during that hospital admission for transplant. But sometimes it's something that happens sort of over time and more slowly.
What's really interesting to me is the other hyper IgM patient that I know also needed a second transplant. And I know that there are others that also needed second transplants. So do you see like anything that could possibly like suggest why hyper IgM patients sometimes do need second transplants? Because that's not like a common thing at all to have 2 bone marrow transplants.
No, it is, luckily, it's not a common thing. We try to do it right the first time, but it is about, there's debate in the field as a whole about whether if even 25% of kids needed a second transplant, but you're reducing the toxicity of the transplant for everybody, and those second transplants go well for everybody, like, where's that balance? Does it make sense to stay on the lower end for everybody and still be okay if you're one of the people who needs a second? And that's a discussion that's happening across other disorders as well, where there's an increased risk, especially as we try to go down on the intensity of the drugs. There's an increased risk for needing that second transplant. And there's even debate in the field on whether you call needing a second transplant a failure. And if you're doing a new protocol and a certain number of kids need a second transplant, does that protocol close and is that a failure? Or is it semi-accepted and you at least continue the protocol? And that's debated even in the field around some of these questions. So I think as we continue to both understand the disease better, understand exactly which drugs we're using will help with getting that graft in at what dose, I do think we're getting better.
Wow, there's totally a lot of variables and a lot of uncertainty. I was just sitting there in awe about like, wow, that's all the stuff you have to think about. Like, I know there's so much more too. Just really goes to show how incredible the work you do really is. So staying along the line of how hard but incredible your work is, how do you help families make the decision of whether to transplant? Because that is a very, very hard decision to make.
It is a very hard decision. I will say our successes, I think, are making it an easier decision for people as we get better. That risk number is going down.
Yeah, as far down as we can get it. Down, down.
Exactly. So it's now like under 10%, and so that's better. It's not, but we want it perfect. It's usually, I would say, though, a series of conversations. It's not a one-time consultation of, your child or you, for one of the older patients I treated, have this disorder and are we going to do a transplant? It's usually over a series of conversations. And I would say there are different components to it and I think everybody interprets risk differently. And so the upfront risk of transplant not going well and having complications, including bad infections and needing the ICU and even mortality, like those risks are all pretty much upfront risks. And some people have more tolerance for upfront risks and less tolerance for like, oh, I could get EBV and it could cause a lot of problems. I could get crypto. And so that's part of it. That sort of what risk feels acceptable. And I think we're all a little different in where we see that. the other part of it, I would say, is that understanding what life expectancy, but also sort of some of the ramifications of hyper IgM, even with a shortened lifespan, is for some people very, very important and informative. And I'd say that's part of what you have been able to do, is share with patients who are making that decision, and some who haven't been transplanted, sort of what does that look like? And is it, there are a lot of people in the world who are on Hizentra or monthly IVIG. And so most transplanters even don't think of getting off IVIG as a reason to go to transplant. It's usually more about what are the other things that could happen in addition to needing IVIG.
That's crazy to hear, given that getting monthly IVIG is not a pleasant experience. No. Like when we had our last guest, Chris, on the podcast, he was talking about that, getting monthly IVIG, and it's not pleasant, right? But no. It's also like there's so much more than that. It just shows like what life can be like with hyper IgM and the reasons to or not to transplant, and just how big of and important of a decision that is.
Yes.
So, shifting to a little lighter note, what's the most rewarding part of the work that you do? Because, again, it's amazing, the positivity and the heroic things that you do at work.
Well, I think I don't take credit at all. I think it's a team. And I would say, though, that the most, or one of the most really meaningful parts is the way in which families sort of accept you into their nuclear family spaces in terms of having these conversations, and in terms of the sort of seriousness of the conversations and of the treatment course. And I think it's a privilege to get to take care of people in times that are so challenging, so fraught. I think, as you know, the majority of boys with significant hyper IgM are diagnosed relatively early in life, and so it's pretty typical that their parents are making really tough decisions around children with, maybe not a lot of medical issues at the time that they're making the decisions.
But a incredibly humble answer that it's a team, and it really is a team. Like when I was in the hospital, I remember all my nurses, everybody that was by my bedside every night, all that. So, yeah, pretty. I hate to use. Go ahead.
Can't leave out the donors.
No, and right? That's what I was just about to say. The most incredible people are the donors that donate. That's right. And now, because we were talking so much about the treatment options that I went through and other people typically go through for hyper IgM, are there any up-and-coming new treatment options that you think will benefit patients with hyper IgM? Anything big on the horizon that you could potentially see being great for hyper IgM patients?
Yeah, I think gene therapy is the big bucket of whether it's stem cell-based gene therapy, whether it's gene editing. There are a lot of approaches being explored that really look at whether you can fix somebody's immune system, either in their body or taking cells out and fixing them in the lab and putting them back in. And I think that is one way that we will be able to, at some point, improve our therapies, or at least increase the different options that are available to people. And the other side gets to this toxicity issue of transplant, and that's the idea that, and it may be combined with gene therapy, that's the idea that there are new approaches to getting rid of or moving out of their niche the cells that are currently resident in your body and making your immune cells. And so most of these they're called novel conditioning regimens, and they're using antibody-based therapy. And so the idea is, instead of a chemotherapy drug that goes in and kills a bunch of cells, you use an antibody that helps you kill just the targeted cells, just the ones you want to either move or eradicate. And so that will likely decrease the toxicity of transplant sometime in the next 5 to 10 years.
When we had Chris on the podcast, that's what Chris is going to go through. So it's really exciting and a little nerve-wracking, but to see how that goes for him. And the fact that we can get the toxicity hopefully down by using this targeted method is very, very crucial to improving success and outlook, because toxicity is not good without a better way to put it.
Exactly. And I do think, that's another place where families are making, or patients themselves are making hard decisions about risk and about the unknown parts of the risk. Like that for some people is not so palatable. Some people don't want to be the first, second, or third patient family on a trial. And some people want to, and that doesn't feel like risk. That feels like, I'm going to benefit from this before other people do, and I'm helping everybody learn how it works. But I think we all make that decision for ourselves.
We do really need people that are going in there with such a positive attitude and saying, I'm going to go in here and I'm going to try this new experimental treatment, and I'm going to see what goes on for the greater good for everybody else. That if this works, it'll work. It might work for other people, and it's just incredible that people are willing to do that.
Yes, exactly.
Yeah. Before we wind down the episode, is there anything that you have to say to our viewers, hyper IgM families, current patients, anything you'd like to add?
I think the most important thing is to use your network. Find your family, your friends, whoever helps you make these decisions and supports you through them, in addition to a medical team that you're comfortable with. And it also doesn't mean that you have to either go somewhere else to get a treatment or stay where you are. It's sort of about talking to a lot of people and listening to a lot of voices and figuring out what resonates.
That's what the Patient Voices podcast is here for, to show as much as we can about hyper IgM, create some transparency for the community. Anybody that's feeling uncertain, that's what we are here for. So I just want to take this moment to thank you so much for coming on to the podcast. It was truly awesome to talk to my transplant doctor on such a great platform for our hyper IgM families and the general immune deficiency population and anybody that's watching. So just want to thank you again for being here.
Well, Ezra, the pleasure was all mine. I'm truly honored to get to be here with you.
Thank you. That means a lot. I'm the one that's honored. Come on. All right. So that brings our episode to a close. I want to thank everyone for watching or listening. Be sure to stay tuned for more episodes like this on the Hyper IgM podcast. I'm your host, Ezra Feynman. Thank you all so much for watching and listening.
Bye.
Thank you for listening. Be sure to follow or subscribe to our podcast, rate or like this episode, and share. It means a lot. I would also like to give another thank you to Blue Jay Advisory for supporting our cause. Again, you can visit the link in the description to learn more. See you in the next episode.